Hello, my name is Richard Poole and I'm an anaesthetic intensive care trainee in the Royal Brompton Hospital and a research fellow there. And as Will informs me, while still a trainee, I am probably older than many of the consultants here, which upsets me, so thank you very much. So I'm going to be talking about episodes of AAGA in the intensive care unit during general anaesthesia. So critical illness does increase the complexity of anaesthesia. We know that apart from other factors, cardiovascular instability that's pre-existing can lead to severe hypotension and cardiovascular collapse when administering just a standard dosage of an induction agent. So it makes deciding on drug dosages quite difficult as a clinician. However, the panel felt that severely unwell patients should still receive general anaesthesia for all surgical procedures and airway procedures and transfers where awareness would lead to pain or distress. With that in mind, we examined reports of AAGA arising from critically ill patients during general anaesthesia for procedures on the ICU, in the emergency department, or during transfers, and classified them as either Class D reports or ICU reports. So comparing it with the UK activity survey data, in the activity survey, 29,000 cases of general anaesthesia were conducted either in the ICU or the emergency department out of a possible 2.77 million, so approximately 1% of the total general anaesthetic activity. And we received 7 reports in NAP5 for intensive care, so approximately 2.3% of the GAs in reports. Of the 7 reviewed reports, all were considered high-quality Grade A evidence. 3 came from the intensive care area, 2 from the emergency department, and 2 from critical care transfers. 5 were female and 5 were morbidly obese. They weren't the same patients. And 4 of them were looked after by consultant anaesthetists or intensivists, and the other 3 by a range of anaesthetic trainees. So again, of these reports, 3 were at tracheal intubation with a rapid sequence induction. In 2 of the reports, the dose of propofol used for induction was 0.4 and 1.2 milligrams per kilogram respectively. And in the 3rd report, which was a peri-arrest case, no induction agent was given at all. However, a neuromuscular blocking agent was. And this was because the patient appeared moribund to the clinical team, but subsequently, upon being extubated, reported awareness of both the intubation and the transfer, in fact, of its entire stay. So an example of one of these cases, a middle-aged patient underwent tracheal intubation in the emergency department for management of acute severe asthma. A rapid sequence induction was conducted with ketamine 20 milligrams and propofol 30 milligrams. Significant hypertension was noted soon after intubation and was treated with bolus propofol prior to starting a propofol infusion. Awareness of the entire intubating process was reported following extubation. So 2 further cases were reported concerning the period immediately after intubation while the patients were still paralysed, and 2 cases were reported during surgical interventions at a later point during the patient's ITU stays. In addition to these 4 cases, another 3 reports came through which involved transfer of patients post-operatively to the intensive care unit, and several themes emerged. One of them was delays from induction of anaesthesia to providing maintenance infusions, the use of non-TCI propofol infusions, the use of low infusion rates at a sort of stock 100 milligrams an hour, and the use of neuromuscular blockade as in all patients. So an example of this was a patient experienced AAGA during transfer and a procedure performed in radiology. The patient reported awareness throughout the procedure, including the painful insertion of a drain, which was described as something exploding in my tummy. So what was common to all of our cases? They all involved neuromuscular blockade. In only one of the cases, a vasopressor was used to support the cardiovascular system during induction of anaesthesia. And we didn't have any cases that used depth of anaesthesia monitoring or nerve stimulator monitoring. However, due to the inherent difficulties in anaesthetising critically ill patients, we didn't judge that all of these cases were preventable. In fact, only 4 of the 7 were deemed to be preventable. Most importantly, from the patient experience, all patients experienced paralysis and distress during their episodes of awareness. 5 of them also reported pain, and 5 of them reported that they had long-term psychological sequelae following their episode of awareness. Now, while we had small numbers, we still were able to draw a small inference that we thought there was a potential for an AAGA incidence of approximately 1 in 4,100, which is potentially higher than compared to other healthcare settings. However, there were some caveats which were to do with the reports themselves and the activity survey. So the activity survey didn't include tracheal intubation for initiation of critical care management as an anaesthetic procedure, and the survey probably didn't or may not have captured all general anaesthesia used for patient transfers. And from an intensive care point of view, it may have been difficult sometimes to judge if a report of AAGA was related to an intervention or during a period of maintenance which was unreportable and so may have gone unreported. Moving on to learning points, low induction agent doses, delays in starting infusions and their low dosages do appear to have contributed to cases of AAGA, especially with neuromuscular blockade being used. We believe that use of target-controlled infusions may lead to more appropriate doses of drugs delivered, and possibly the use of checklists, such as in NAP5 for induction and intubation, may lead to appropriate doses of anaesthetic agents being delivered and prevent delays in maintenance infusions being administered. It was also noted from that case that obtundation of mental state doesn't guarantee absence of consciousness. So in obtunded patients, care must also be taken to provide adequate anaesthesia for both surgery and airway interventions. However, it's important to say that there are valid concerns about the adverse effect of induction agents in the critically ill. There are some patients who would be catastrophically harmed by high doses of induction agents. In these cases, it may be appropriate to use lower doses, and therefore in these patients, an explanation of the risk of AAGA and reassurance and assistance may be required. And therefore, to summarise, AAGA in the intensive care may not be completely avoidable. Due to our low number of cases, we stop short of making any statements regarding recommendations for practice. What we do is suggest potential research possibilities. Those include the utility of depth of anaesthesia monitoring in the ICU setting, which is unknown at this stage, and the use of sympathomimetic agents for induction of anaesthesia, such as ketamine for improving cardiovascular stability, and also the role of TCI in both anaesthesia and the transfer of intensive care patients. Thank you very much.